passionate about finding solutions to improve healthcare despite increasingly limited resources. Originally from the Upper Peninsula of Michigan, he naturally focuses on practical approaches to the industry's problems. Brian has 17 years experience with Stroudwater Associates, a national firm that is recognized for its leadership and advisory services to hospitals and health systems. His expertise is focused on both affiliation planning and facility strategies and financing. Brian holds a master's degree in health service administration from the University of Michigan and is recognized as a fellow by the American College of Healthcare Executives. He has worked in every region of the country, from Alaska and Hawaii to Maine, where he resides. Brian,
Hello.
I'll turn it over to you.
Great, thank you. Well, I appreciate that introduction, and as Kim mentioned, growing up in a rural part of Michigan and about a town of 3,000 people, I can imagine quite a few people on the call can relate to that in communities that you're currently serving, and can relate to the idea that when we are in small towns and the bonds of people in small towns are so tight, that the idea of how we work with folks from outside the community, or in Maine, I guess they say, from away, it can be an intimidating and difficult subject to raise with our boards and to talk to with our medical staffs who have independent practices, or maybe working with the hospital but want to maintain the scope of services that they've historically provided. So today's session, and then a little bit of a preview for next week's session, really breaks this large issue into two topics. The first of which we'll be covering today is about positioning for the future, understanding all of those changes that are happening in the marketplace, and particularly how they affect this question of partnerships and what kind of partnerships you might be wanting to develop for success. So as we look at being a Michigan person, I like to use Michigan analogies, and you see here the Model T. Henry Ford pulled together the first assembly line to put together vehicles back at the turn of the century, and really wanted to be able to make these cars accessible to working class people, and focused on efficiency, safety, and accessibility. And I draw that analogy to much of what we're working on in healthcare as it relates to improving the way that we are able to practice across the continuum of care to affect cost, quality, and population health, or what is now known well as the IAHI's triple aim. So in rural communities, we have real value to offer. And one of the key messages I'd like folks on this call to understand is that beginning with the value that we are providing to the communities, and really being able to quantify and understand that we are able to approach this question of partnering, whether that's with a neighboring health system, whether that's with a coalition of other small rural hospitals, however that is, but we're able to approach the position from being one of strength. We have a lot to offer our communities, and frankly, we have a lot to offer the healthcare system as it relates to management of total healthcare expenses in a very efficient way, kind of hearkening back to Henry Ford's assembly line here. So in today's presentation, many things happening in the industry, and I'm just going to touch on the highlights of those. My assumption is that many people on the call have sat through many presentations or read many articles about the trends that are happening, but there are a couple that are really important to understand as it relates to what's driving affiliations. And then, as I mentioned, we do want to understand what value rural delivery systems bring, both the hospital side as well as the physician practice side. Some cases, long-term care and other home care and other services, but there really is a tremendous amount of value to be offered in the future of the delivery system. Kim did a nice introduction. Stroudwater, to many of you, is known. We've been involved with rural facilities and rural planning and rural strategy for 17 plus years. Many of you have seen us presenting and understand that we're here and really dedicated to working within this part of the marketplace. So broadly speaking, from an environmental perspective, we've seen a continuum of changes, and we hear often the acceleration and pace of change seems to really be different these days. It's happening at the federal level. We certainly know that the Affordable Care Act is continuing to evolve, that there still remains some level of uncertainty on aspects of that the Supreme Court will be deciding this month. But we also, I think after a number of years, are able to see some very clear trends around reductions to price, much more of an emphasis on quality, et cetera. As recently reflected by the Obama administration, reflecting that there is an anticipation that 50%, a goal of 50% of all Medicare payments will be in alternative payment models by 2018. So these changes are happening quickly at the federal level and will continue to really accelerate in the future. Because we work nationally, we see states also really exploring a lot of different kinds of payment systems and innovations. Oregon being an example of a state that has moved to really population health Medicaid payment so that the dollars are fixed and that the providers are expected to work within those budgeted amounts and really be at risk for the services that are provided. We know Alabama is moving in that direction. Other states are following, and so a lot of action happening there. And then within our commercial insured populations, we see a lot of changes, and some of which are really being able to direct the patients to lower cost, higher quality providers by doing narrow networks. There's even a program that we've heard of where a Blue Cross Blue Shield plan is offering cash incentives for folks to use ambulatory surgical centers. So these are pretty significant changes, and it just, as we talk to leaders out in rural settings, it seems to be coming fast and furious, and sometimes is difficult to make sense of, for sure. If we think that any of these changes are going to end anytime soon, this slide kind of puts into context many of the economic drivers for why healthcare reform was started and, frankly, why it's accelerating. On the public side, you see the lines there that reflect the Medicaid and other entitlements, as well as the Medicare underfunding. These amounts are in trillions. There are a lot of zeros there. And just as a point of comparison, you look at those amounts driven by demographic changes, the aging of the population, utilization trends, et cetera, and you see that relative to the value of the economy overall, and you just see it's an enormous challenge for us. And we're also, of course, within rural, highly dependent upon public funding as it relates to sources of revenue for us. So these changes that happen, the effects of the reform as it relates to really looking at payments, really starting to pay for quality, understanding that there are very specific programs now for acute care hospitals around incentives tied to quality, incentives that are tied to readmissions, et cetera, and that in rural, critical access hospitals in some ways are excluded, but it is important, and we often communicate and want boards and other leaders to understand that these changes are affecting rural hospitals, critical access hospitals, particularly when we start to see market share changes, people who are looking at publicly available quality data and maybe choosing alternate sources of care based on their perceived quality. We also know that there are a lot of new programs and incentives that are being created around saving dollars and reducing costs. ACOs is an example of those. There are certainly other models, but these are all things that are the alternative payment models that the Obama administration and CMS have really targeted to be increasing, and frankly because they're working. They are creating some savings. Depending on which study you're looking at, those are varying, but they're working, and we'll see some evidence of that here in just a moment. So I just want to pause for a second and tie this back as it relates to these trends and some of the changes that are happening at the federal level, and note that the effects of many of these changes are also happening in large hospitals. And so as we talk to systems and as we talk to other providers that you may think of partnering with, they're facing many of these same factors. And I think it's important as you start discussions around what partnerships could look like, it's always important to understand what that potential partner's realities are as well. And again, in rural and in our hometowns, we might look to the larger systems and think that they're just vast repositories of money that are available for our use. And the reality is they're getting squeezed themselves. So I think that's an important piece here. As we look at what's happening out in the consumer marketplace, we're seeing consumers being a lot more picky around where they get care and how much care they get. Some of that is certainly driven by high deductible health plans. Many hospitals that we talked to have had really revenue cycle disruptions associated with being able to collect on this and making sure that there are very clear processes in place. There's a lot more transparency. It's easier to see differentials, and frankly in rural, one of the challenges that we have is how we're pricing our services, because we have so many standby costs to provide critical services like emergency, that it's really impossible to be price competitive for outpatient surgery, for example, with an ambulatory surgical center that shuts down at 3 o'clock in the afternoon and doesn't open back up again until 7 o'clock the next morning. So there's a real challenge here, and the consumerism can really work in rural's favor and can really, from a loyalty perspective, help support the hospital. And these are important factors for us to be considering as we think about the positioning in our markets and with healthcare reform. It's important to see, we're seeing a lot of employers that are contracting directly with what you might think of is preeminent tertiary care centers across the country. A couple of them are shown here. These are certainly not an exhaustive list. I think the important thing to see here, again, as it relates to where people are getting care, there certainly are some rural hospitals that are providing services that might be directly affected as it relates to orthopedics, for example. But for the most part, these are highly specialized services, and it might not directly affect, but one of the things that certainly we're seeing is some of these folks, Walmart, for example, CVS, Walgreens, they're also moving more aggressively into primary care. And many of you on the call might remember suburban hospitals and other larger hospitals a couple decades ago being undercut when physicians were doing what were called carve-outs and developing their own centers and really trying to compete with hospitals with a lower price. And in some cases, there are some risks in the marketplace with some of these centers going into primary care and doing the same thing, really trying to undercut the rural hospital's primary care system. And we think that's a big risk, but also we see that there are some opportunities strategically to avoid any negative effects with that. So what are the effects of this in terms of our operations? Well, inpatient use pretty much across the board seems to be declining. This is the national statistic, 11% decline in the last decade or so. Pretty significant when you look at variation in utilization across the country. Significant variation. This is for some rural states out west that we looked at, and frankly expected to continue to decline in the future. So from an inpatient perspective, rural hospitals have not been highly dependent on that as a source of revenue in the past, and likely that will continue to diminish as a source of revenue in the future. So we're really thinking more from an outpatient and ambulatory perspective. We've all heard a lot about ACOs, accountable care organizations. Many of those, many parts of the country now are affected by them. It wasn't too long ago I was working in some rural areas in the Midwest where we didn't believe, or the leaderships didn't believe that ACOs would really come into play there, and they certainly have. It's important to note that a good half of these ACOs are actually physician-led organizations, so they are not always the rural hospitals that are involved, and that does create, again, some additional risks and threats associated with reducing hospital-based care and having, if our primary care physicians aren't on board, having them working at odds. One of the other interesting things that we're seeing in ACOs is that they're targeting the higher dollar expenses, and the two places that they're looking for that really are on the hospital side and specialty care, not directly related to, again, a lot of what we do in rural hospitals, but the other one is post-acute care. It's actually the number 2 spend for many of these areas behind hospitals, and what we hear from ACOs is that there's a tremendous amount of variation in the cost and quality of that post-acute care. So when we think about our swing beds, and when we think about how swing beds relate to ACOs, this is a really important question for the future as the change happens in the marketplace. Just as a point of information, I know that folks will have these slides. California actually has a pretty long history with ACOs because the Blue Cross Blue Shield of California plan put together an ACO, actually launched it in 2010, so it was specifically for public employees in a program called CalPERS. And so they actually have a very long history, some of the best information out there as it relates to how utilization changes over time when there are shared savings involved. So consistent with some of what we're seeing and thematically consistent with what we'd expect with lower utilization in the future. All of these are accumulating, of course, to lower than expected costs. These are estimates that have been prepared over a number of different time frames as it relates to spending, and you can see from the black line that the actual costs are actually trending at the lower end of all the range estimates of where we would have expected them to be. So these and many other things are happening to restrict the availability of resources and costs. And I'm going to transition this now to how are we starting to think about this from a hospital perspective, and how specifically does it relate to our positioning in the marketplace? Because remember, we're positioning for the future here. These payment system changes that we're seeing from volume to value as we move fee-for-service as a lower part of our business and start thinking more about quality and population health. We're seeing more competition based on quality and payment, price. And there's a real understanding that the reductions that we're seeing are real. It's really a structural change is the way to think about this. And so in the past, 10, 15 years ago, when we were doing rural work, we knew that Balanced Budget Act might have taken some resources away, but the Balanced Budget Refinement Act and other things kind of came behind that, added resources back in, and so there's a realization in the marketplace now that these things are here to stay, and they may take a variety of different forms, but we're living within this new world. And as I said at the outset, the new world in many ways is characterized by the triple aim and a focus on patient value. The financial implications of this can be devastating, and it's important as we think about risk, the cost, bending the cost curve, if we think of that from a national perspective, those costs nationally are in many ways your revenues in the hospital. And so if the cost curve is bent and we're not able to really transition into a different kind of payment system, you see these kinds of trends. You see negative operating income, and on the right, you see eventually that eating into cash and investments to where that all goes away. And unfortunately, we've seen that starting to happen, the tip of the spear here, as the market changes, leading to more closures than we've seen at any period previously, except maybe if you go back to the 80s and start thinking about the effects of DRGs. So these risks are real and are really starting to call the question from a community's perspective as it relates to, do we want to be completely independent? Do we want to be partially independent? Do we want to be fully owned by a system? This range of opportunities. And that's really what has driven a large part of the increase in membership in healthcare systems. At the end of the day, it's about survival. And when faced with the community not providing any services or doing it under a system membership, you see, folks are opting to be parts of systems. Now, we would not want folks on this call or any others listening to, in the future, to really wait until you've reached that point. And one of the things I appreciated about being asked to do this talk and next week's talk is that it's really part of a proactive strategy, and that affiliation is not a last resort. It doesn't have to be the last lever that you pull to try to maintain some level of services. It really does have an opportunity. It does have an opportunity to be a strategy that can help your organizations achieve its objectives. And that really changes this around quite a bit. It's not waiting till too late. And in next week's webinar, we'll talk about the specific process and some things that you'll want to look at as it relates to indicators about when's the right time. But for now, let's just agree that it is absolutely something that's strategically important to be talking about in recognition of all of those changes in the industry, but also in recognition of the unique role that you play and the value that you provide to the community. The path that we're working along really has what we would consider to be three major elements and steps associated with it. If any of you have seen my colleague Eric Schell's presentation, he takes about 4 hours to explain this one slide. So he does it very comprehensively, and I'll just hit the highlights here. The first element of change that we see happening is the increase of efficiency and quality. And yes, we do believe that these are very relevant and very important changes for critical access hospitals to become more efficient, to measure and provide higher quality. And frankly, the hospitals that have closed on the map that you saw previously, they were just unable to meet those market expectations and did not retain enough business locally and were not efficient enough in order to be right-sized for that community, and that's the reason that they went out of business. So we need to develop competencies to survive the initial incentives and pushes to do things differently. The next challenge right around the corner is to make sure that the physician alignment component is maintained. And I say maintained because many rural hospitals have made these investments historically, whether through employment, developing clinics, or just having really loyal physicians. But as we start to transition towards population health and as the financial incentives grow for us to be managing care differently, then it is really important that the physicians in the rural hospitals are really working collaboratively in that way. So that can be patients at our medical homes. It can be specific programs to target frequent flyers or high utilizers. But these are the kinds of things that really make and accrue a lot of value to the rural hospital in terms of having the physicians be on the same page. Ultimately, we really will have to move into different systems of care, and this is when we get paid on a fully populated basis, and we start thinking now across, what are we really doing from a wellness perspective? What is the hospital experience? How can we move things to outpatient? What's the appropriate utilization of rural settings relative to much more complex care? And likewise, do the larger hospitals really need to be doing simple procedures, gallbladders and whatever, or they should actually be getting out of the higher cost in tertiary settings? So each of these three transitions is going to be playing out in the marketplace, in your areas. They're playing out at different rates. We appreciate it's kind of difficult to know where we are, but we know right now everybody's really focused on efficiency and quality, and working within fee-for-service. So this now gets to, and for the next 15 or 20 minutes, I really want to highlight this issue of value. At the beginning, you recall I said we were going to talk about some of the affiliation trends. Now we're really transitioning into, from a financial perspective, as we play through each of these stages, how do we create conversations with potential partners around where we're creating value? In this first example, and I'll highlight this, but I just want to offer for anybody on the call to follow up with me, and our contact information will be included at the end. These are models and information I'm happy to share and help you work through in terms of what it looks like for your organization. But what this really does is it starts to create a different kind of conversation with potential partners by going through and looking at the three elements of the potential financial contribution. The first one is what your existing cash flow is and making sure that that's stated appropriately. So, if you're at break even, we really need to take out the non-cash items like depreciation and have a true representation of cash flow. That's really what's important overall to be emphasizing. And we know many rural hospitals work at or below break even, but on a cash flow basis, they're positive. So let's just start with understanding that that's what's important. There is a process to go through if you're a critical access hospital and you're looking at a certain kind of partnership that can meet the Medicare rules, to be able to do cost allocations from systems to critical access hospitals. This is not always happening, but it is important to at least kind of value what that could potentially look like. So you look at administrative costs and how much of that would flow through the critical access hospital's cost report. A number of systems are doing this, again, all in compliance with CMS regulations, but there is an economic value associated to a healthcare system in this case for being able to take some of its overhead and spread it to critical access hospitals and make sure that they get value in terms of being able to access specific expertise at the system level, contracting expertise, what have you. So that's the second piece. And then the third piece is really important, and it's recognizing that through a system relationship and a partnership, you can really start to affect the quality of care. You can have better clinical processes, better referral systems, and when you do that, you're creating additional contribution margin for a potential partner. And so we went through and developed a way to really try to quantify that in terms of what the transfer benefit would be. And this would largely be in a fee-for-service world, so it's very relevant for today's market. And you do that by taking a look at the size of your service area, what the economic value of each discharge is in your service area, adding a buffer in for outpatient services that would also be likely provided, diagnostic and whatever services, and then really kind of boiling it down to their contribution margin. So in this example, you see that this organization is losing a couple $100,000 a year and might very well think, geez, who would ever want to partner with us? And when you take a look at these three steps, you actually realize, I know the numbers are small there, but you start to realize that it's a potential $3 million contribution of benefit to a potential system partner. So we go from the mindset that we're losing money, we don't really have a lot to offer, to, geez, there are a lot of different ways that we could create a partnership where there's plenty of economic value, and we're not just here to bang our tin cup and ask for handouts. So a very, very important thing, and again, I'll extend the offer that if folks are interested in thinking this through, please contact me, and I'm more than happy to help you do that. Now, I just spent 20 minutes earlier talking about how the market was changing from fee-for-service to population health. The very first example I showed in terms of thinking about potential value that you offer was completely fee-for-service oriented. So let's think now about how some of what you can offer as potential value in your positioning in the market, how does that relate to population health? And we just define this very basically, that when we look at population health, we're looking at value. And value, is really got two components in it, quality and cost. And that we can increase value mathematically and practically by increasing our quality and keeping the same cost. We can keep our quality the same, and we can decrease cost, and that would result in higher value. Or the goal, and a lot of what people try to go after, is being able to both simultaneously increase our quality and reduce our cost. So what's our experience look like in rural in doing that? Well, a number of years ago, and this has been validated several times, we went actually out and looked at what is the experience itself in terms of how rural physicians and hospitals practice, and what are the actual differences when you look at hospital service areas and you put them into two categories of rural and urban. What are the actual differences in spending? And it wasn't a surprise to us because we visit many rural communities and we know this, but in spite of all the extra payments that we get on a per unit basis, our overall spending on a per beneficiary basis is actually lower in rural. Overall spending is lower because, as many of you on the call likely do, resources are managed aggressively. The physicians don't practice with as many bells and whistles, so to speak. And in urban settings, there's a lot more diagnostic testing and just overall higher utilization. So when we're in a population health world, it doesn't really matter what our critical access hospital per diem rate is. What really matters is what is the overall spending per beneficiary, and how are we doing in managing those costs? How are we doing relative to the industry? And nationally, we're lower. And that's a very good place to be starting from. And I believe we have the ability, because we've got all this alignment with our physicians, to take it even lower than that. Kind of gets to the future hospital, the kind of value equation of the future. And it also ties back to the issue of aligning with our physicians. And so we drew this example using ACOs because it's a very established framework now, and one that we can understand. In an ACO, remember, when you look at the rules of ACOs, hospitals can actually belong to multiple ACOs, but physicians have to be assigned to one ACO. So right at the get-go, that kind of tells you that the physician in the primary care practice is what's at the center of where the value is going to get created. If I'm a hospital and I can belong to multiple ACOs, I'm kind of a vendor. But the physician component, and particularly within rural, those physicians that we're employing and working closely with, that's really where we have the opportunity to work with value. And so what we're able to do then is, in some case studies, think about medical management programs, and some commercial insurers are providing medical management fees for primary care practices. There are specific programs and pilot programs in some states to be able to target diabetic patients and other at-risk patients and get some shared savings of being able to manage their care differently. We know there are lots of opportunities for better coordination of care. And then ultimately, as we think about what happens in terms of the rural hospital's relationship to the system, we are able to effectively manage population health at the local level using a lot fewer resources. And this becomes one of the really important value propositions for the future. So this becomes one of the ways we, Stroudwater, really strongly believe rural hospitals can be demonstrating value, not just in this fee-for-service world where we're able to organize transfers differently, but really in the population health world where we're organizing care and providing care closer to home differently, with patient-centered medical homes and other models to do that. In quantification terms, if you look at the aggregate medical spending, medical cost per person in a typical primary care physician's panel, and you multiply those two together, you end up with about $16 million per primary care physician as it relates to that total spending. So you take 5% of that, and you say through better coordination of care, through the development of protocols, through a lot of different kind of blocking and tackling clinical management, there's some real dollars in terms of savings there. And one of the things that we want to be able to really emphasize as it relates to the rural hospital of the future, these are dollars that you are earning and should be getting good portions of as it relates to shared savings back to you. So when we are talking to potential partners and we're coming with an abundance mindset about how we can build the different healthcare system of the future, part of that has to include the attribution, the credit for who's doing the work and how you are providing downstream cost savings in your setting, and we don't want all of those resources to accumulate at the system level. Okay, so we need an attribution model, or we need kind of the accounting system to recognize where value gets created so that rural hospitals get credited with these changes in the future. And there is certainly a lot of value as we kind of move into the fully population health world to maintain access to care. And this is one study from the Commonwealth Fund. There are many, many others, but it really drives at this issue of when there are access problems, there are downstream higher costs. And as we are moving towards population health and working within the rural setting to improve population health, to increase quality and decrease costs, we play a very valuable role in doing that. One of the areas rural hospitals are starting with right away, particularly those that are at risk for the health benefits, self-funded, is by looking at their own hospital employees. And frankly, if we can work, this is data from Proven Health Analytics, if we can make an effect within our own workforce in hospitals, then then we have a lot of potential for doing it outside of our workforce. And part of that is because, as you see in the slide, a number of folks in terms of people who work within hospitals and the health system who are at risk and struggling are significantly higher than the general workforce population. So our own workforce is a challenge, and there are, I know, a number of folks that are starting to work in this regard, including some folks in Illinois, for example, who are putting in medical wellness centers and really targeting hospital employees to start to change some of these trends. So again, really good changes happening in the industry. So to kind of summarize this and then give you a little bit of a preview for what's going to happen next week, when we do all this work and in rural, we provide great quality, we're working to provide higher quality, we're really working to save money on per capita costs, so the average spending per person. But when we do that, if we're in a fee-for-service world, it undermines our financial success. And again, if you've seen my colleague Eric Schell's presentation, we call that the shaky bridge. We call that the shaky bridge going from fee-for-service over on the left-hand side here to this new payment system. And I really wanted to be able to provide 3 examples of how we see you providing value along this entire transition. But we do recognize that depending on how many reserves you have, depending on your marketplace and how competitive it is, this journey is perilous, and I know it's a difficult one. So next week, with this context of the changes in the industry, which we will not go over again, and these potential ways of value, the question now is, so what do we do about that practically? How do we organize it? I can gather the information and we'll extend again an offer to work with you on some of these tools because they're very easy. Those really help start the conversations, but what would we really do from a process standpoint? And that's what next week we'll be really highlighting is how you go about this over time, understanding the sensitivities we have from a board and a governance perspective, and a lot of market-specific questions I'm sure you have. So I'm going to pause there, and Kim, open it back up to you if there are any questions that you might have or others might have.
Brian, thank you so much. If anyone has any questions, it's *2 to unmute your phone line. Otherwise, you can feel free to type your question into the chat box at any time here. Brian, how do we communicate our value to potential partners?
Yeah, I think it's a great question because if we're just speaking practically, there are a variety. There are a lot of different perceptions, misperceptions, information, and misinformation out there as it relates to how rural is valued in the delivery system of the future. Many potential partners might have had historical ways that they've related to rural settings. Maybe the only time they've ever heard from a rural hospital is when the rural hospital wants a bunch of money and they're broke. So it can be challenging. I think that when we're talking about potential partners of affiliate critical access hospitals, there's more of an understanding, more of a birds of a feather, but we still can have different worldviews as it relates to what we're trying to accomplish. So I think these tools that we talked about today are a good start. But I think that we really need to start with an acknowledgement that we are, with a potential partner, really looking for if there's a mutual benefit to the relationship, and to be able to design a kind of relationship that makes sense for both parties. And part of that is about communicating the value that we contribute and really connecting it to the expectations that they may have from either a system perspective or another rural hospital perspective.
Thanks, Brian. Does anyone have any other questions? Brian, rural hospitals value their independence and control. How can they retain that in an affiliation?
Oh, yeah. There are a lot of ways to do that. I think, again, in maybe this is a little preview to next week, but there were a lot of I guess the best way I describe this is the historical model that we used was more hub and spoke oriented. And as we think about affiliations of the future, the hub and spoke was the big system hospital sets up affiliations with outlining hospitals. It's a very command and control oriented arrangement, and once you signed on to that, which many rural hospitals did as a measure of last resort, that there was no ability to retain control, so that there was kind of a a complete relinquishing of that. And what we're seeing today, in part because systems